Yep, good.
Good afternoon, everyone. I'm so glad to see you today. This is for round 2. We are going to be doing balancing on air, peripheral neuropathy, and fall risk. I have Fran West with me. She is a nurse practitioner with Center for Neurosciences. She works in a hospital over at TNC, and Fran has done several presentations for us, so we love having her here. So welcome back, Fran. How are you today?
Thank you. I'm well, thank you. Hope everybody else is. This is a little disconcerting. I see you and then you all.
So I'll go off in a minute. You won't even have to look at me. But we do have an online audience that's here, and so they are watching as well. So if you're watching from home, please feel free, if you've got a question for Fran, to put it into the chat, and I will ask Fran afterwards when she is all done. I'm going to go ahead and put your PowerPoint up for you, Fran, so that you can go ahead and get started.
All righty. So good afternoon. As she said, my name is Fran West. I am a nurse practitioner on strictly adult neurology. I only do inpatient. I did do outpatient quite a while ago, but it's been a long time. So bear in mind that my perspective on some things is colored by the fact that I do acute care, not long-term. But what I often see are people with chronic problems who have exacerbation or, some acute episode for them. Okay, so now this is titled neuropathy, peripheral neuropathy walking on air, but my personal experience with people who have neuropathy is that it doesn't feel like walking on clouds or air to them. I think this picture is more the kind of thing they're talking about. It's either painful or they just have no sensation, which is very disconcerting when you can't feel things, or they have some combination of the two. But it's rarely pleasant, So when we're talking about peripheral neuropathy, this is damage to nerves outside the central nervous system. So we are not talking about anything related to the brain or the spinal cord. It's everything after it exits off the brain or the brain stem or the spinal cord. So these are just some basic statistics. That's a lot of people, 15 million people, and these are just US numbers. And Europe, but really primarily Western Europe, because that's where we have the most interaction with data. And WHO really, this is a hard thing to document, especially in undeveloped countries. They got plenty of other problems to worry about besides peripheral neuropathy. In the United States, 2 out of 100 people have it. 8 out of those 100 will be older than 55. But the thing about peripheral neuropathy to remember is it's kind of an umbrella term. Doesn't tell you what, why they have it, what the underlying issue is. And that makes a big difference when it comes to treatment. So just your basic anatomy review. Again, as I already said, peripheral is not the brain and not the spinal cord. So every other nerve in your body is a peripheral nerve. The interesting thing about peripheral nerves to kind of bear in mind is they can regenerate. As far as we know, they don't in the central nervous system. This is the last great frontier. Cue the Starship Enterprise. Neuroscience is, literally one of the last great frontiers for research because there's so much that we don't know, including things about, like you're born with so many neurons, and then by the age of 2, you've already done a lot of pruning, and that sounds horrible. You're like, oh my God, I'm losing neurons every day. Well, yeah, but on the other hand, do you want to keep the ones you're not using? Maybe it's a better idea to build up neural networks. So that may be something that affects, and it already is actually affecting treatment of a lot of chronic conditions. So, your peripheral, I think I got a little carried away with these anatomy slides because they're kind of cool. But as you can see, the way the system works is, and bear this in mind, pain is a brain phenomenon. It is your brain that tells you have pain, because the way that loop works is you have, so for example, if you're talking about your feet, you have spinal thalamic tracts. Message starts down there in your feet, travels up to the spine, there's crossover at different levels, goes up, gets diverted to the appropriate section of the brain for interpretation. So That system has to work, and then the system that returns. So, afferent going towards is sensory, efferent going away is motor. And so if that sensory pathway isn't working, what's the interpretation going to be, and how are the muscles going to respond when you send a signal back? And so there's many places in that circuit where things can go wrong. Okay, so classification. So NINDS is the National Institute for Neurologic Disorders and Stroke, which is a mouthful, but it is one of the institutes within the NIH, the National Institutes of Health. And so by their definition, there are over 100 different types of neuropathy, and that's specifically peripheral neuropathy. I will tell you that there are neurologists whose fellowships, whose specialty is just in these peripheral neuropathies and things. Okay, about 30% of them, which is a big number in this country, and it just reflects kind of our general state of health, is related to diabetes. And that can be both type 1 and type 2, although I think it's a lot more prevalent in type 2 that we consider adult onset. Okay, and so if you say 30% of people with peripheral neuropathy, so that's going to be, say, 30 out of the 100 people that have it. Of those, roughly a quarter of them have neuropathies directly related to diabetes. I think that came out wrong, but you get the idea. And then about 30% of it, so there's like a rule of 3 in a lot of medicine. Roughly a third of people have it, and we don't really know why. And it's called, when we don't know why, we call it idiopathic. That is a term that literally means I can tell you what you have, but I can't tell you why you have it. And that actually includes things like high blood pressure too. Okay, and then the remainders, lots of reasons. It can be trauma, it can be medications, and we'll, I'll go over that a little bit more. Actual nerve compression, etc. So if you only have one nerve that's affected, that's a mononeuropathy. Mono, one, right? If you have several nerves, it's called mononeuritis multiplex, which is basically like, or plexus, where you've got a collection of them, but they're kind of in a related distribution. Like you have a big plexus up here in the shoulder, you have a big one here at the femoral area in the leg, and that is for this whole general area. Polyneuropathy means you've crossed the midline and you've got it on both sides. And it's not unusual if you have neuropathy to have it worse on one side than the other, but typically people will, unless they have a very specific injured nerve that's causing the problem. Most of the time what we see are people with polyneuropathy. In other words, they got it in both legs or both arms or whatever. It's usually feet too, feet and legs, most common. Okay, and you can get real nitpicky with all this stuff, but clinically speaking, if I have to write a note, then I'm precise in my language when I'm discussing it with somebody with neuropathy or with family and everything. They don't need to know quite that much minutia as far as terminology. Most of it you can figure out when you see it, but that's not really the important part. So there are hereditary neuropathies, and they are not common. HMSN1 is literally hereditary motor sensory neuropathy 1 through 5. So there are like 5 different classifications of this disorder. This Dejerine-Sotos disease, if you don't know what it is, you do not have to worry about it because it's a polyneuropathy that shows up in children. So if you got to this point in life and you don't have it, do not worry about it. Inflammatory, so immune mediated. So Guillain-Barré, that's what GBS stands for, Guillain-Barré, and then CIDP. CIDP stands for chronic, idiopathic, demyelinating, or actually inflammatory, demyelinating polyneuropathy. Both of those conditions, the problem is that it's autoimmune, the body attacks itself, and what it's attacking is the sheath that covers the nerves. So think of like copper wire with insulation. These diseases attack the insulation. And so what is that going to do? Think of it as electricity going through, because that's really what we're talking about, neurotransmitters, is that's going to disrupt the flow of electrons pretty much, right? So you can have patchy things, or you can have just constant stimulation, which can lead to pain. Are y'all familiar with multiple sclerosis or NMO or anything? So that's a demyelinating disease of the central nervous system. So this is the thing that's different with these guys. These are peripheral nerve disorders, and there are subsets. There's acute demyelinating, encephalopathy with mononeuritis. There are, like I said, many different ways to have neuropathy in subsets, but the bottom line is it acute or chronic? Guillain-Barré is an acute problem, and generally will resolve. 80% of people get it, have a full recovery. That 20% is like a bell curve. Some of them will have minor residuals. Some of them, may be severely debilitated. I have, in the course of my career, probably had one person that I know died of it, or from complications of having it, and that is vanishingly rare. But certainly I've seen people with pretty profound disability from it, but that also, again, is pretty rare. Most people recover. If it becomes a chronic condition, because it's a one and done, they have Guillain-Barré, you treat it, and then they go through recovery, rehab, etc. If it becomes a chronic condition where they have recurrent episodes or they never get better and you have to continue treating them, that flips over to CIDP, which is the chronic form of it. So they have an ongoing autoimmune process, like somebody who has rheumatoid arthritis or somebody who has lupus or something. They have to be on medication all the time to suppress this immune activity. That's probably the main difference from those to take home. So acquired metabolic and toxic. So DPN just is diabetic peripheral neuropathy. We do use a lot of shorthand, sorry. Metabolic and nutritional neuropathy. So if you have malignancies, it can be either the disease or it can be the treatment for the disease. So it can certainly be a lot of gut disorders that involve the bowel. If you have some kind of absorption problems, the old pernicious anemia, for example. And the reason I bring that up is that affects your B12 absorption. If you are B12 deficient, you will have a neuropathy. So I had a good story about that one. Anyway, and of course exposure, depending on what you do for a living. There are chemicals out there and things that are toxic to the nervous system. And that certainly would include peripheral nerves. And in this country, nutritional deficiencies are not a huge issue for us, frankly. Most of our grains and cereals and things are B fortified, and it's the B vitamins that are usually implicated if there's a deficiency causing neuropathy. So you look for, okay, if you're deficient in this, what else is going on that could affect why you're not absorbing this? I mean, heck, I think, what do we put in orange juice even has vitamin supplementation in it. So let's talk about the focal or multifocal peripheral neuropathies. Remember, focal, one, multifocal, multiple sites. And they're just different ways of saying pretty much the same thing. So compressive neuropathy, carpal tunnel, right? And what do they do to treat that? They do a release because you want to take off whatever's pressing on that nerve. Radiculopathies. So everybody knows sciatica, familiar with that term, right? The nerve pain that starts low back, buttock, goes back down behind the knee, often goes down to the side of the foot. Or like the old Bugs Bunny commercial, oh, my lumbago, same thing. That's all pretty much that kind of thing. The reason it's called radiculopathy, so picture the vertebral column, right? That you have bony, vertebral bodies anyway, so that protect the spinal cord itself. So this is not a problem of the spinal cord, it is a problem of the nerves as they exit the spinal cord. Then with those vertebral bodies, they have little arms and legs, and they articulate. In other words, they join with each other and they form a canal. It's called a foramina. And those nerve roots exit out that. So if you have had injury, if you have bulging discs, and remember the discs are the little cushions between the vertebra, and that's the thing that over time kind of dries up and causes you to shrink. But you can get bulging discs, you can get fragmented discs, you can have the bones shift relative to each other, you can get bone spurs. These are basic degenerative changes, essentially. If you have those things, that can cause compression on that nerve root as it goes through the tunnel. That will give you weakness, numbness, pain, or all of the above. And that is one of the most common reasons that people have surgery, whether it's neck or low back. If it's low back, that's peripheral. Those are radiculopathies. You can have cervical radiculopathy, but again, that's going to be more, that's going to be a little trickier. We have to do a careful evaluation because if you're up here, you tend to have these problems where you have curvature, right? So neck and lumbar spine. If it's up here, we have to be very careful and make sure we're also evaluating the spinal cord itself. But surgery is sometimes the way, really, you have to be very careful about that. We've been doing these kind of surgeries for over 100 years. You have to be careful about who you do it on, because if you've had it for a long time, some of that nerve damage is permanent, and even if you have surgery, not necessarily going to fix it. Or, and again, if it's multi-level or, just all up and down, unless you're willing to get instrumentation, like literally hardware going up and down, and that's has potential complications of its own. It's really, one has to be careful about getting a surgical evaluation and whether or not surgery is the appropriate treatment. It's just so you know that it's not a cure-all of everything, and just because people have some of these degenerative things does not mean surgery is going to fix it. So phantom limb and stump pain, well, that makes sense, right? And if anybody's known somebody who has had any type of amputation or anything prior to that amputation, especially if there was infection or something involved, I guarantee you these people had pain. No doubt in my mind that they've had pain, whether it was traumatic. What we see mostly in my line of work are not people with traumatic amputations. It's people who have vascular disease. That gives you pain right there if you're not getting circulation. That's painful. But then they have neuropathy, because often these are people, if they have peripheral vascular disease, they often have diabetes, etc. So once you take away the problem, they're still kind of hardwired for that pain loop. And so this is where therapy comes in, and there's some interesting things that they can do to help with that phantom pain. Sometimes medication is enough for people, not always though. And one of the things they started doing, I think with the Vietnam vets, was actually visualization. Look in a mirror and look at it and basically retrain your brain and try to get that circuitry rewired so you stop receiving those signals. But, what if you use a prosthesis? Every time you gain or lose probably no more than 10 pounds, it probably doesn't have to be a lot. You might have to have that thing refitted because it changes the shape of things. If you've got a new one, you have to adapt to it. You always have to do a visual and make sure there are no issues with the stump itself, nothing that's any sign of infection or rubbing or anything. So post-traumatic neuralgia, that would be like, say somebody who had a motor vehicle accident, broken bones, anything like that, things that cause trauma, essentially. Trauma isn't just limited to soft tissue or bones. It can certainly happen to nerves too. You can get shearing. I remember years and years ago, a woman whose granddaughter was in the car seat involved in a car accident. Well, the car seat worked and everything, but she still had shoulder. I'm trying to remember. I think it hit her. It probably got her right there at that plexus, and then just had basically it wasn't completely plegic, but it was a very weak arm. She could use her hand and everything, but couldn't really pick it up. And I think it's because she got injured right at that, brachial plexus. And then post-herpetic neuralgia. The over 55 crowd knows about that one. Even if you haven't had it, I guarantee you know someone who has it. So this is the thing. Herpes virus is that whole family, HSV. And so varicella viruses, which is what chickenpox is, which is what shingles is, same family. The thing about those is you have them for life. If you've ever had it, it never goes away. Doesn't mean you have active infection. Doesn't mean you're going to get shingles just because you had chickenpox. But when it goes quiescent, which it kind of does, you have a non-acute case, it goes away, you don't have your rash anymore, you don't have any pain anymore, it goes and hides in nerve endings. So if it activates, that's you often feel pain long before you have a rash, actually. So it's a good reason actually to get the vaccine, frankly, because it's a miserable state. It's miserable when you have it. And the problem is, again, it lies dormant in nerve endings. And so when it activates, it cues those nerve endings. So now what have you done? You've just set up a pain cycle, like a pain circuit. And so, with post-herpetic neuralgia, what we're trying to do is quiet that down, ramp down the signaling and try to close off that pathway. Um, I'm trying to think, I used to see this when I was a new nurse. I worked on an ortho surgery unit. And in those days, people would often get both knees done at the same time. We put them on those continuous passive motion machines and stuff. I'm really dating myself. But I'll tell you, it was like day 3 after surgery, they'd go into AFib and get shingles because stress can bring it out. So if you're overtired, you've been traveling, even happy stress. Weddings can be stressful for people. Certainly funerals can be stressful for people. But again, stress can actually unmask these things. And that's true for any of the peripheral neuropathies. You have a chronic condition, a chronic neurologic condition, you're under stress for any reason, including infection, it can unmask your symptoms. Doesn't necessarily mean it's getting worse permanently, but it'll be worse in the short term with other stuff going on. So just recognizing that, that you can have flares of these things. Okay, so generalized polyneuropathies. What is that? That's, again, both sides, more than one limb involved. Most common, diabetes, demyelinating. We talked about GBS. AIDP is less specific than Guillain-Barré. AIDP is still an acute demyelinating disease, though. The CIDP, which is the chronic form, CMT stands for Charcot-Marie tooth. And those are, again, not common conditions, but they are inherited polyneuropathies that also go along with some skeletal deformities and things. Their toes will start to look like this, they get contracted, and that is part of that is because of the neuropathy. So that's what CMT stands for, Charcot-Marie tooth. If you haven't heard of it, don't worry, because you're not going to get it at this stage of life for the most part. But it's out there. Like I said, many of our conditions are not common, so mostly the people who have them and their family members know about them. If you haven't heard of them, chances are you're probably not going to get it. But yeah, it's sort of one of those unfortunate things that we get that's degenerative as well. So I bring up alcoholism because, again, remember I was talking about one of the things that can give you a neuropathy is vitamin deficiency, particularly B12 deficiency. So one of the things that we see with long-term alcohol use / abuse is they develop a pernicious anemia, which essentially means they are lacking a factor in the lining of their stomach, not the gut, the stomach itself, that you need to absorb B12. So even if you have a reasonable diet, and often they don't, even if you do, you're not going to absorb it properly. So we do ask about that. There are certain labs that we look at that can kind of give us a clue. So for example, everybody's probably familiar with anemia. If it's iron deficiency anemia or like anemia of chronic disease, you tend to have small little red cells that are pale. They call it microcytic hypochromic, little cell that's pale. Well, if you have a B12 and or a folate deficiency, you got big red cells. They're still not bright, they're not normal, but they're big, they're macrocytic. And that is one thing that leads us to start asking more questions if we don't already know when we see that. So that was my story for today. Had a kid that came in with, woke up one morning about 5 days ago, and was having trouble walking. I mean, literally didn't have balance. She wasn't necessarily weak, but, she was having numbness and tingling in her feet up to about her knees and having trouble walking. Well, okay. So she got admitted to us, and they actually started her on something called IVIG, which we'll talk a little bit more about. And that is a treatment for Guillain-Barré. They were thinking, oh, she's got a Guillain-Barré. But we're like, because Guillain-Barré doesn't really present like that. It's kind of a gradual onset. There's a clear time of onset, but it doesn't just go from like 0 to 60. We're like, But bottom line is, questioning her without mom in the room, she does nitrous oxide. Y'all familiar with whippets? Anybody ever heard of that? It's like when people get the cans of whipped cream, that's the laughing gas, the nitrous oxide. Well, that doesn't show up on drug panels and things, so a lot of kids are doing that. I mean, that was around when I was in high school. Now you can just go buy them. They look like little torpedoes. And so sure enough, I looked at her B12 and it was not completely gone. And I've seen them when they're like 0, we can't even detect it, but it was very low normal. And so then I started thinking, well, what's going to affect that? I'm thinking nutritional stuff. She had a history of restricted eating, like anorexia nervosa, but that was years ago. And so I'm like, well, is there an absorption issue? She doesn't really, her labs don't really look like she's got the type of anemia that reflects that. Well, but again, given age and everything, we're like, So yeah, but the treatment is still the same. Replace the B12 and then some therapy. But it's real interesting because when you do her exam, her legs would actually kind of start to scissor and she couldn't really control them. I'm like, okay, take, it's called heel to shin. I want you to take the heel of this foot, run it up and down the shin of the other. And she couldn't really do it because she has sensory ataxia. Those nerves are damaged. She doesn't get the right messages going up here to control the muscles. So,
And how old was she?
early 20s. But man, I had a guy that was like 49 one time, and it's the same thing. Initial interview, nope. But went back when his son was not there. Come to find out he's doing that too. I remember we get one about every 6 months. We had a guy one time who, let me think, he was in his 20s too, maybe 27, something like that. Nice kid, worked, responsible person. Did those whippets though, loved those things, and they're not illegal or anything. But he was one of the ones that came in and had like 0 B12. And all of a sudden, he was just, and he wasn't just his feet everywhere, was clumsy and not working right. Let me tell you what he did for a living. He packed parachutes for people that jump out of planes. I'm like, okay, where do you work? Yeah, I'm not doing that. Okay, HIV, notorious because what does HIV do? It is a disease that suppresses the immune system. So they can get any and all infections, and it's opportunistic. So the condition itself can cause neuropathy. The drugs they use to treat it, although they're better now than they were, years ago. And then, the opportunistic infections are the big ones. And when I say opportunistic, it's not limited to, infected toes, feet, fingers, whatever. They get like meningitis and things like that. They get nasty infections. And we talked about B12 deficiency. And then toxin exposure. So toxin is a broad term. You can certainly have on the job, like somebody that works in the cleaners, for example, or some kind of a chemical plant, or, work in a place where they produce like medical gases, or, all kinds of things that would fall under that. So we do always ask people, what do you do for a living? Or if they're retired, what did you do before you retired? What are your hobbies? What do you do with your day? Because that'll often give us a clue if we're trying to figure that out. Chemo, that's a big one. Chemotherapy, there is such a thing as, chemo-induced neuropathy, just like there's such a thing as chemo brain. It is a real thing. It does affect the nervous system, both central and peripheral. ART is what they used to call the old heart, so it's antiretroviral therapy. Again, that's kind of mainly the HIV drugs. You don't really see it with other antivirals, like we take for flu or COVID or something, simply because you don't take them for that long. You take them for 3 days, you take them for 7 days. That's not the problem. It's ongoing therapy. It could be illicit drug use, fairly obvious. And heavy metals, certainly. So like in her case, before I really knew the full story, I'm like, well, she doesn't have any exposure that I'm aware of, but I'm going to check the copper. And there are conditions, there are metabolic disorders like Wilson's disease and stuff, but they're, once again, vanishingly rare. So doesn't mean we don't think about them, but that's not the first place you go. It's, look for the usual stuff. If that doesn't pan out, then you start digging deeper and looking for zebras. And then, industrial chemical solvents. We talked about that. Uh-oh, I'm stuck. Oh, wait, maybe, yeah, still stuck. Yeah, I had no idea what she did that made that better. Okay, so manifestations. So motor weakness, so motor meaning movement, weakness or atrophy. You can actually lose muscle mass, just muscle bulk because you're not using them. And then the sensory loss, if you have large fibers, and large fibers for us mean the ones like when we talked about radiculopathy, the nerves coming off the spine. Think about how long the nerve that comes from here all the way down to your foot is. That's large fiber. Those are going to affect, more so than the small fiber, which is more like diabetes, which, the damage happens down sort of like at that cellular level, that matrix with the cells and the small blood vessels. But with large fiber, it's going to be proprioception. And what proprioception is your sense of where you are in space. So if you ever see us, the cops took all their testing from us, when they're doing their field sobriety test, that's all our stuff. And one of the things you'll see them do is something called a Romberg. I want you to stand with your feet together, turn your hands out, and close your eyes. And because alcohol is a central nervous system depressant, it's going to affect the cerebellum, which is your coordination and balance area. And they're going to lose, if they don't break stance, they're going to be very swaying. And if they break stance, well, but I'm here to tell you that's probably not a valid test, and you could argue it in court if you're over like 55 or so, because it's kind of use it or lose it. You know what I mean? Some people just for other reasons, and simply because maybe they're not very active or doing yoga every day, may not have the greatest balance if you put them to the test on that anyway. So, you have to take everything in context. But that proprioception, so that Romberg test is really actually not a coordination test, it's a sensory test. That's why I'm like, you could argue that if it ever came up. Small fibers, pain. That's why diabetic peripheral neuropathy is probably far more associated with pain than even like people think, oh, well, sciatica and everything. Sciatica is painful when it flares, but when it settles down, people are pretty functional. If you have diabetic peripheral neuropathy and yours is painful as opposed to just numb, it's painful 24/7. And certain things will aggravate it, absolutely. Reflex loss, we do actually check those. Most of y'all probably haven't had your reflexes checked since you were had a sports physical, or maybe were in the military. It's just, not, actually I'm probably being mean. Other people check it besides us, but not many. But that does tell us something. If you have peripheral nerve issues, one of the things, and it's just rounding out the exam, it's another clue, another piece of the puzzle, then I would expect, like if you had a Guillain-Barré, one of the hallmarks of that condition, one of the things we're absolutely going to look for is loss of reflexes. If you've got sensory changes or you got weakness, but you still have reflexes, I don't think that's what the problem is. So it does help us figure out which pathway to go down. Autonomic symptoms. So the thing to remember about the peripheral nervous system, divided in two, right? You've got the autonomic, which is the automatic, stuff you don't think about. Your breathing, your heart rate, digestion, etc. And then there's, the skeletal, voluntary, muscle movement, things like that. So you can get neuropathy of the nerves of the autonomic nervous system. Anybody know somebody with Parkinson's disease by any chance? Yeah, so one of the problems with Parkinson's disease as it advances, because it is a systemic disease, is that those folks, at baseline they have balance problems, right? But it affects their autonomic nervous system. So they have horrible problems with blood pressure management. Sitting down or laying down, they're fine. They go to stand up and their blood pressure just plummets. And it's hard to stay upright I've seen them when they drop down to 60. And that's the top number. So you see, bear that in mind too. I had a case probably, we're 2024. So I'm going to say 9 years ago of a fairly young woman that came in with a Guillain-Barré, but she had kind of a variant, and poor her, because she had pain, which is not a hallmark of Guillain-Barré most of the time. It really isn't. Horrible pain, and she had autonomic dysfunction because of it. To the point where we actually had to have a feeding tube in her for a while, just because her gut wasn't working. It did recover, but it takes time. So, don't forget that it can also affect stuff like that. And what we usually see are things like that. It's called orthostatic hypotension. When you change position, particularly if you go from laying down to sitting, most people are okay because they're sitting, they'll recover it, but it's that sitting to standing and walking that can really drop them. And that, of course, is dangerous because injury. Dizziness, you can get flushing, so you can get redness. ED is erectile dysfunction, which think of that, if you think about it, at least in my mind, that's really another form. It's probably a little more complicated than that, but that is autonomic mediated, and it has to do with tone of the vessels, right? The venous vessels, because the medications they use to treat it allow for dilatation so you can get blood flow. So that's still going to be affecting nerves to some extent. So, I can make everything into a neurologic problem. This is a germatome. Very wonderful, useful thing. Because when we talk about, you can say you have sciatica, but that is actually specifically L5S1, is pretty much what sciatica refers to. But, if you talk to a neurologist, if you talk to somebody who does ortho, you talk to an orthopedic surgeon, whatever, and you tell them where your pain is, and they may ask you, they'll tell you where the problem is. This is what allows us to localize these things. You see, and it'll tell you right there. Here's the L1 nerve root, innervates this area, L2, S2, S3, etc. So it's very clear cut. And then that's also kind of how you can figure out if people have multi-level disease. Now, this is what you had to do before we had magic machines, right? So, but it's still useful. It's still useful. We had a woman that came in yesterday. She came in a couple of days ago. We got asked to see her by a neurosurgeon because she had foot drop on one side and some weakness and pain for sure. And as it turned out, he looked, that we got the imaging and everything. He goes, "This is not my problem. This is not a surgical problem. This imaging absolutely does not fit her presentation. I don't think that's the issue." So he's like, "Ask neurology to see her." And we're like, "Oh, geez." But, she turned out to be interesting. And what we think she actually had was a post-herpetic neuralgia, because it turns out she'd had shingles probably about 3 weeks before. And then, and we literally pull this thing out. And we're like, okay, 3 separate dermatomes. Did it cross the midline? So we do have these real discussions about this stuff, because that's kind of how you figure it out, really. Okay, so symptoms: loss of feeling, freezing. Sometimes people just feel cold, 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 cold. Other people have burning hot, 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 hot. It's kind of individual. Tingling. Tingling can be present all the time. Tingling can be when somebody touches you. It triggers that response. Hypersensitivity, or what we call allodynia, which is a response out of proportion to the stimulus. And generally speaking, it's not pleasant. None of these things are particularly pleasant. Sharp or stabbing pain. Burning sensation, which kind of is the flip side of freezing. And I must have been kind of tired when I did this, because to my mind, loss of feeling and numbness, well, they're not entirely the same. There is some nuance there. Numbness implies you really don't feel much of anything at all. But loss of feeling is complete loss of sensation. And you'd be surprised how many people have that. And because it happens over time and they've learned to compensate for it, they're not even aware of how bad it is until you do the testing, which we'll talk about. Okay, so patterns. We talk about, if you ever look in our notes, we talk about stocking and glove distribution, because in peripheral neuropathy, the pattern is that it starts distal, away from the body, away from the heart, and moves up. And that's why, it's, picture it putting on your socks or putting on gloves. Starts this way, moves up. And then a little bit on the sides, but really that stocking and glove is the classic presentation. Now, if everybody would just read the book before they come in, it would help us a lot. Okay, so was there a recent viral illness? Because that can trigger one of these autoimmune demyelinating syndromes. So we always want to know about that. Viral illness, diarrheal illness, certain bacteria are associated with things like GBS, like Campylobacter, so alcohol abuse, vitamin deficiencies, dietary habits, a lot of, and the other thing I don't think I talked about in here, oh yeah, there it is, good, gastric bypass, because folks who had the old-fashioned gastric bypass, I don't think they do, like the old Roux-en-Y, I don't think they even do those procedures anymore. What do they have? They have horrible absorption issues, right? Because you rerouted things and you shortened things and and there's some things that are absorbed in the acid environment of the stomach, and there are some things that are absorbed in the basic environment, and I mean that in the chemical sense, in the chemistry sense, of the gut. So if they have any history of that, or they've got a long history of IBS, or they've had colon locked off, or short bowel, because the short bowels where really most of the absorption happens, that's important to know, because they absolutely need to be checked for deficiencies. Are they taking supplements? This is where dietary habit comes in. most of the time, if you have a good diet, meaning, what we would consider heart healthy, lots of fruits and veggies, not a lot of processed food, etc., you're not really going to be deficient. And again, a lot of our stuff is fortified in this country. So unless you have an underlying health issue, you don't really need to take a lot of extra stuff, frankly. And your body actually uses it better if you get it from a dietary source as opposed to just a vitamin. Past medications, so that can be something they're not even taking now, but they took in the distant past. People that have weird like movement disorder, tic disorder things, it's not necessarily a nerve problem, for example. They might have been on the old antipsychotics that can cause, extrapyramidal symptoms is what they call them. So, that's also a good thing to know. If they're having any kind of complaints of abnormal sensation, you always want to know, what are you taking now? What have you been on in the past? As best that we can determine it anyway. We talked about HIV, and diabetes is the big one, of course. So diagnosis, history, everything is truly, you got to know the history, right? And some people are very good historians. Some people are not. Some people are vague. And I'll tell you, having been a nurse for a long, long time, used to drive me nuts when I was in the cath lab, so pay attention, that I would get all these men would come in and be like, I don't know, ask my wife. I'm like, okay, why is your wife not here then? If you can't answer my question, you bring the person with you that has your medication list. So, but I think it's important to know what your issues are, what you're taking, and why. You should always know why you're taking something, because we're a society that suffers from polypharmacy, right? Lots of people taking lots of medications. Know what you're taking and why. Okay, and and sometimes you do wonder, you're like, do these things all just cancel each other out? I know that's being kind of cynical, but again, because the doctors, bless their hearts, are, often we're seeing multiple specialists. They're all looking at the thing from their, perspective and prescribing meds in their realm. Now, it doesn't mean they don't look and see what else you're on, but, things can fall through the cracks. Something could have been prescribed that was meant to be temporary and never got, discontinued. You'd be amazed. Well, maybe you wouldn't. I don't know. But it's always a good idea to just update that thing periodically, keep a list on you all the time. Okay, so what do? We do definitely blood and urine testing. We're looking for, and also never underestimate what can happen to you if you have kidney or liver dysfunction. That can absolutely affect a lot of these things. An electromyogram nerve conduction velocity, that's what EMG NCV means. So sometimes we're trying to figure out, is this a muscle problem? Is it a nerve problem? Or is it the junction of the nerve and the muscle? And the way we can see that is to do one of these studies. So what they do is put electrodes, along a nerve pathway, and they will deliver current. And then they watch the current, and they can tell by the speed of it, that's where the velocity comes in, the shape of that curve, how long it lasts, duration. So there are a whole lot of things they can look for. Guillain-Barré, we don't really do it anymore, but that used to be one of the tests to determine that disease. It was something called F-wave latencies. So it's an abnormal nerve conduction velocity, specific and basically diagnostic for that condition, because it reflects the fact that you got that Swiss cheese coating on the nerve. So that disrupts the pathway. And so it changes the speed. Let's see. And then EMGs, the needle part of the test is they'll take a teeny tiny needle and actually put it in the body of the muscle involved. So EMGs are usually done, both upper extremities, both lowers, or one on each side, or, whatever the problem is. You can get all four, you can get one, depends on what we're looking for, what we're trying to figure out. But they'll put that in the muscle, the body of the muscle, the belly of the muscle, it's called. You deliver that current, and what you're looking at is the contraction and the relaxation of the muscle. And that can tell you a lot of information too, because remember, we are the world of the weird. We get things like myositis, myelopathies, all those kind of things. And again, particularly before we had the magic machine that is the MRI, this is how you diagnose stuff. We probably do less of it now than we used to, but it's still very important, especially for some of our more rare, like, upper motor neuron, neuromuscular diseases, things like that. which hopefully none of you will ever experience. Spinal Tap. Anybody ever see that movie? This is Spinal Tap? It's a great movie. Anyway, so that's the good old lumbar puncture. You go in with a small needle. It's smaller than the ones we use to start IVs. It's just long, so it intimidates people. But and then we get fluid out and we run tests on it. The basic thing we do is cell counts. What's in there? Do you have white cells? Do you have blood cells? What's the protein? What's the glucose? Because there are parameters for all those things. There's a normal range for all of those. And so that can help us look for things like infection, meningitis, encephalitis. It can help us look for cancers. You can get CNS lymphoma, for example. If we see protein, high proteins, which is a sign of breakdown, that is something that's characteristic, again, of Guillain-Barré. So that is often, we still do those for Guillain-Barré. We definitely do it for the central nervous system ones. So like multiple sclerosis, what they call NMO, which is neuromyelitis optica. So we do actually do a lot of LPs, even to this day. Imaging, so CT or MR. So CTs can be useful if you're looking at like spine, if you're worried about radiculopathy, so, if somebody's got sciatica, look at the bony images. I mean, sometimes they'll do plain films and do what they call flex X, and you can do that in the neck and the lumbar spine. They're actually looking to see, what's the alignment of your bones, and they usually do it in more than one view, right? In radiology, one view is no view. So you're usually going to do at least 2 or 3 views because you're trying to approximate 3-dimensional imaging. But if you want to look at the nerves or the spinal cord itself, you need an MRI because that's soft tissue. And that's what's going to see that. And what you're looking for, like, so suppose somebody had a fall and we think they maybe had a vertebral fracture. Well, we can see that on, we can usually see that. And then CT, by the way, just so everybody knows, is just a very fancy X-ray. It is still X-ray. It's, bone is what it sees well, bone and actually blood, which is why we do them for strokes first, because you're looking for blood. But, before you give somebody a clot busting drug, you want to make sure there's no blood up there. Anyway, so if you're doing that CT, you're going to see the fracture. It's going to be conservative management unless you see something on exam that's particularly worrisome, but it's going to be, pain management, physical therapy, etc. When you would go back and do an MRI, for example, is if people did not respond to conservative management. You've been doing that for 6 weeks, or actually, I think the criteria now for CMS are 3 months, and then you can go back and do the MRI, and if you're still seeing swelling and irritation around that area, then this might be somebody who would benefit from a treatment like putting some bone cement in there to restore a little bit of height. Then that's, let me think, there's vertebroplasty and kyphoplasty. Vertebroplasty is they actually go in with a trocar and go in there, make a pathway into that little, usually it's one of the facet joints or something, and they put the bone cement in to stabilize the fracture so it's not pinching on that nerve so much. With a kyphoplasty, they'll go in usually from both sides, and they actually balloon up to restore some height, disc height, and then put the cement in. And then, of course, ever after, you can tell if somebody's had that because we can see the bone cement on the imaging. We used to have this rad tech that would, with the leftover cement, she would make little animals. So in that bag, in our little, control room window, we had all these little, critters. Let's see. Yeah, that's probably. Tools of the trade. I brought them so you could see them. I walk around with these every day. We all do. Reflex hammer, and there are different kinds of reflex hammers. This is the one I like. It's called a trauma tuning fork. So remember I was talking about proprioception? When you are checking for neuropathy, the 2 things we really look at is light touch. And people will tell you, this side does more than this, or in my feet I don't really feel much, or when you touch it, again, it might be tingly or it might be painful. But the other thing I'm going to check for, because we get asked to see people a lot for falls, like this person's falling all the time. Why are they falling all the time? And so we have diagnoses, things like multifactorial gait disturbance. But one of the things I'm going to check for with neuropathy, or if that's what I suspect is going on, vibratory sensation. You got to use the big one. And you just put it on there, right? And I usually I'm like, all right, how does it feel here? If you start in your hands, You feel the vibration, et cetera. And then I'm going to check the knees. I'm going to check the ankles. I'm going to check the toes. I'm looking for that vibratory sensation, because if you lose vibratory sensation, again, those spinothalamic, think about that spine, and then the thalamus is a relay station in the brain for getting those messages to the sensory parts of the brain. So if you lose that, that's going to affect your balance, because you're not getting the right messages from your feet, and you're standing on your 2 feet, and so you'll be walking along, and if you have loss of proprioception, loss of vibratory sensation, even if it's decreased, you can probably compensate. But if you pretty much lost it and you have numbness, you're not going to know what you're walking on, right? So if you go, if it's a little bit rocky, if there's like, a crack in the sidewalk, you're walking your dog, and you better pay attention to where you're going, because you will not get the message from your feet. Nobody should stand like that. I will just make you dizzy. But you see what I'm saying? You have to be aware that you don't have that sensation, because you will not recognize changes or transitions in what you're walking on the surface that you're walking on. And that's a very common reason that people fall. And so if you've got that, it's not like all hope is lost, but these are folks that we, depending on the degree of it and everything, that we think really do better with assist devices. Use a cane, use a walker. Because the last thing you want to do is stick somebody in a wheelchair, because they're such a fall risk, because, then they're going to decondition and then be even more of a fall risk. So the goal is to preserve function. But part of that is recognizing what the problem is, because you can't treat it if you don't know what it is. Okay. We talked about this. You can tell I don't pay attention to my own thing. I obviously am like 3 slides ahead. So deep tendon reflexes, that's this puppy. So they're really stretch reflexes. Now, here's the other thing too. I actually don't have very much in the way of reflexes. As far as I know, there's nothing wrong with me. So lack of reflexes isn't always pathology. It's all about context. If I don't have reflexes, and I have somebody who's had long-standing diabetes, or I have somebody who's relatively young, otherwise healthy, doesn't have diabetes, doesn't have back issues or neck issues, and they don't have reflexes, I'm going to go, if I'm asked to evaluate them for falls or changes in sensation, again, it's another piece of the puzzle. And that might be somebody, for example, that I think, maybe you do have Guillain-Barré. The vibratory, tactile, literally light touch. If we think there's a spinal cord problem, like here, especially thoracic or in the neck, I don't really do it for peripheral neuropathy, but I could. It just doesn't add much to my evaluation in that context. But pinprick, I walk around with safety pins. I got a refill. And the reason is, if I open up a safety pin, one-time use, sharp or dull. The head of the safety pin is dull, and then obviously the pin part is the sharp. So I will go down and check. Sometimes I do it on the dermatomes. Sometimes I'm just checking feet, whatever. And that is to determine if people still have that distinction. Can they tell the difference? Gait is a huge one. You can tell a lot by the way people walk. Anytime you go into a neurology office, probably in an ortho one too, they'll want to watch you walk. There are many conditions, including Parkinson's, for example, that they are clinical diagnoses. They're not based on imaging. They're based on your exam, and gait is one of them. So you can definitely tell a lot by how people walk. Are their feet together? And I'm not talking about people that, turn their feet out or something, but is it a narrow-based gait, right? And what's their stride length? Do they shuffle? Do the feet come off the ground? Do they stoop? Do they have arm swing? Because none of us think about that, but we have arm swing that helps us maintain our position. Is it antalgic, which is just a way of saying that's a person who walks like they have pain, like they're favoring a hip, they're favoring a knee, their back, whatever. You walk differently with those things. So you can learn a lot by watching somebody walk. And that is definitely part of our exam. And it's interesting too that sometimes people with a pretty bad neuropathy will almost toe walk. They'll kind of tend to lean forward and walk more on the balls of their foot. Or here's the other thing that happens in people with diabetes, because, I think y'all are probably familiar with the fact that they get the foot ulcers. So the foot ulcers, part of the reason that happens is they'll get those fallen arches that, if you look at somebody who's had long-term diabetes or has bad peripheral neuropathy, they basically have fallen arches. It's almost like a deformity of the midfoot, and it kind of comes out a little bit in the middle. Sometimes their toes are kind of crinkled up like this. But what that really means too, because they can't feel, is that their stance, how they stand over their knees, over their feet, is different than somebody who doesn't have that. And that means that pressure is distributed differently and in places that it normally isn't. And so they will develop calluses that can then become sores in those places. And that is one of the things that contributes to those ulcers. I love this story. Monofilament testing. All right, has anybody gone to their primary and they get that little thing out that looks like fishing line on it? Yeah, and they start poking you like this. It pretty much is fishing line. But that monofilament testing is what it's called. It's flexible, it's not sharp or anything, but that's what they're testing for, is that fine sensation, and can you discriminate from like toe to toe, from your toe to the ball of your foot? Do you feel on the top of the foot? And these are the places that they test. But this test is such an interesting story. This actually developed, I knew I should have looked this up because I forgot. I believe it's in Missouri. So there's a place there where they do treatment and research on Hansen's disease, which is leprosy. What does leprosy give you? Body-wide neuropathy. I mean, you lose, all those nerves die, and that's, kind of part of the problem with that disease. They lose all their peripheral nerve endings. And so this was a test that was developed there to assess these patients over time. How is the disease progressing? And they would do this test. And so it sort of got adopted over into primary care practice to, monitor people with diabetes. And it's part of it's screening, basically. If they know you have diabetes, they're going to do this periodically to check for any signs of neuropathy, because if it's there, you want to check it early, catch it early, I should say. So, reversible causes. Food allergies. Can't say I've seen a whole heck of a lot of that, but it does happen. And it may just be because of what I do. I'm probably not the person that would be treating them. But certainly with any allergy that's causing you any symptoms, whether it's your hair falling out, rash, gut issues, whatever the case may be, because it can be anything or all of the above, then it's diet modification. But that's tricky, because it's hard sometimes to figure that out if you have like a gluten sensitivity or some of these other things. That can be a difficult diagnosis. There are certain medications, so anti-epileptics, anticonvulsants, whatever you want to call them, anti-seizure medications. If you stop them, then people will get sensation back. But I'll tell you, as somebody who's treated a whole lot of epilepsy, that's really not that common. But so like topiramate, for example, is an epilepsy medication that gets used a lot for migraine management. Those folks, when they take it, we tell them, you might get some tingling in your face, your finger, it's really fingers and toes, but it's transient, it's temporary, it's not dangerous. I mean, if it's persistent or really bugs you, then obviously we're going to try something else, or maybe it's dose related and we treat that. But not really an issue that much. But I had a guy one time years ago when I was still in clinic that just had a terrible neck, and he really wasn't very old, and he had a terrible neck. He had a lot of neuropathic pain. So I'm trying to titrate him up on gabapentin. At that time, they had just come out with a formulation that was extended release. So we're trying to find something for him, and so I'm working on this with him. And one day he just calls up in a panic because he's like, "I'm numb, I can't feel." I'm like, "Well, you're taking like 2,400 milligrams of gabapentin, so your choices are pain or numbness." So that is not the outcome we're looking for. But that for him was kind of the reality of being on that high dose of medication. It's probably stopping the pain signaling, but it's probably stopping everything else once you get at those higher doses. So you can get that numbness too. Hypothyroid. You have anything weird going on of any kind in your body, certainly sensory things, mood changes, skin changes, whatever, check a thyroid. It's an easy thing to do, because if your thyroid is out of whack, your whole body is out of whack, and no matter what we treat you with, it won't work as well if your thyroid isn't working. So that easy test to do. Good return, may not be the problem, but it's, check. Okay, we talked about carpal tunnel. So the key thing with carpal tunnel is, treat it early, because once you've got compressive nerve damage that's been going on for months or years, chances are even releasing it is not going to reverse the condition. And one thing we found out from sleep studies is that, we used to think it was all the repetitive thing, like people who do work on cashiers and things like that. One of the other things that we realized is that there are a lot of people who sleep like this or like this or like that, and they're causing compressive neuropathy during their sleep. So one of the things that we do advise people to do if they're having some carpal tunnel symptoms is to put on a cock-up split. It's like the little sleeve that goes from here to here. It just keeps the wrist in neutral, and see if that helps. And it will certainly at least keep you doing this in your sleep. Let's see. Oh yeah. So, and the reason we talk about this with the diabetic peripheral neuropathy and the testing on the feet and everything is if you catch it early enough, and it's still like in a mononeuropathy phase, or it's just limited to one area. If you can get tight glucose management and treat what other vascular risk factors they have, if they've got high blood pressure, manage that. If they've got high cholesterol, because all those things cause damage at the microscopic level, at the microcellular level. So treat that, you might actually get some reversible. As a general rule, though, by the time somebody gets diagnosed with diabetic neuropathy, they pretty much got it. And your goal is to tighten up everything so it doesn't get worse. Okay, so partially reversible and reversible. Yeah, we talked about the carpal tunnel, the vitamin deficiencies. If you've got chronic systemic illness, which certainly that's diabetes, and you've got neuropathy from that, or like a CIDP, or just those radiculopathies, again, that's not going to change. And that's what I mean by be careful if you're going to have a surgery on your back or your neck, because if you've had these issues for a long time, even them doing some decompression, if it's going to help pain do it, might not necessarily reverse neuropathy though. And pain can be separate than the nerve injury. Let's see. Some of the drugs. So, does anybody, what was the name of that movie from the 60s, the really creepy one? Stanley Kubrick, they had the guy's eyes open with the toothpicks watching. Yeah, that one. I don't think anybody's used disulfiram since then. Well, that's probably not true, but it's out there, but certainly in a hospital setting, I never see that. So anticonvulsants, phenytoin, topiramate, which we talked about. Phenytoin you rarely see anymore, really rarely see anymore. In theory, again, possible with all of them, really don't see it though. Chemo medications, vincristine, paclitaxel, cisplatin, immune modulating drugs, thalidomide. So these are things that are used to treat like lung cancers, etc. So the general public is not going to come across them. And I think most of them probably could cause some issue of it, but there are ones that are more notorious than others. And all the oncologists know what they are. It's part of their teaching. If they have to have a patient that's going to be on one of those, they will warn them that this could happen. The thing about it is, though, if you start developing neuropathy symptoms, it doesn't necessarily mean they're going to stop your treatment, because what's worse, neuropathy or cancer, untreated cancer. But if they can try a different agent, but that's not always an option if you're in treatment. If somebody's working in a place with big vats of chemicals, do every safety thing that they tell you to do, especially around solvents, because what happens with solvents, a lot of them, especially if they're organic solvents, they're going to get absorbed into your system, even in trace amounts that can cause damage, like significant damage. So infection, not so much the infection itself, certainly, but the drugs we use to fight infection. Now, metronidazole, which is Flagyl, is actually a fairly common drug. The fluoroquinolones, ciprofloxacin, levoquin, which is levofloxacin, those are all pretty common. The incidence of neuropathy from them is pretty low, but they are known to have that as a potential side effect. Excuse me. Let's see, what else? Oh, dapsone. So these, and the tuberculosis, so some of these ones that we use, oops, sorry about that, I went the wrong way. For, we don't have anybody locally that I'm aware of that's even under leprosy treatment anymore, but some of these are like isoniazid, which for people who have like multi-drug resistant, especially the things like TB and everything. So these are heavy duty medications. The average person is not going to get exposed to this stuff. But, just recognize if you have to be on it, somebody better warn you that you may get some kind of neuropathy from it. And I think that's one of those things that you do need to warn people about. I don't necessarily read them the entire package insert, but things like that I do warn people about if I'm using something that might cause that. Okay, I have a little bit of a block on my thing here. So, what are the causes of the diabetic, which is the big one, right? That's the one we see most frequently. Long-term high blood sugars, high cholesterol. Once again, I repeated the same thing. Oh, well. Well, actually, even just high blood sugar, whether it's sustained over a long time is one thing, or whether you spike from time to time. In general, that's a sign of just labile blood pressure. So the less controlled you are, the more likely you are to have it. Smoking, whatever, the 100 different chemicals, one of the things that it does is significant vasoconstriction. All the vessels clamp down. So what if you're somebody who has, atherosclerotic disease or something? The last thing you need is something affecting your blood flow to the small spaces. And that includes like the distal vessels in your brain and your heart. There is an actual neuropathy specific to long-term alcohol use, and that's what it's called, alcoholic neuropathy. We probably have let me think, it's alcohol use disorder. I don't think we've changed the terminology. We probably should, because the idea is to be descriptive, not judgmental. And, but long-term alcohol use absolutely can give you a neuropathy. I have seen it many times. And often these people are just not aware of it. And it's neuropathy independent of the B12 part of it. So these people can get it from like 3 different pathways, basically. Genetic factors. There are genetic neuropathies, but again, not common. Treatment. So the things that we use to treat, like, chemotherapy-induced neuropathy, not very effective. I mean, we're going to fall back on the same things we use for people who have, sciatica and trigeminal neuralgia and things like that, which is, you start with things like gabapentin. Duloxetine is another one. So we use SSRIs, SNRIs, which are antidepressants. Sometimes we use tricyclic antidepressants, definitely gabapentin. In the same family as gabapentin chemically is Lyrica, which is pregabalin, and those work on GABA receptors. So GABA is an excitatory neurotransmitter in the brain. So what most of these things are doing is, it's like chemomodulation or neurochemical modulation. We're trying to downgrade, downramp the signaling pathway and mute it, essentially. Does that make sense? So that's really what you're trying to do. Is you may not be able to necessarily break the cycle fully, but if at least, and if you have a chronic pain condition, nobody should promise you they're going to, make it magically disappear. If you're already hardwired for pain, nobody should promise that we can make that go away. If we can, if there's some treatment or combination of treatments, because it's usually a combination of things that works for people best more than any one drug. You approach it from different pathways, and some things are non-pharmacologic, so I'll talk a bit more about that. But the bottom line is, what we're really trying to do is, modify it, really. Okay, baclofen is an antispasmodic amitriptyline. That's a TCA, tricyclic antidepressant. Ketamine, you hear about that, and you'll hear about that as a migraine rescue medication. Our experience with it, which is the reason we never set it up over here, is like people coming in, like the status migrainosis, and treat with it, is our experience has been, it works great when it's on, but the minute you turn it off, it starts ramping back up again. So we're like, okay, topical agents. There's a lot of stuff that you can get at the compounding pharmacies. Well, they will take many of these drugs and give you a topical formulation. Now, I have had people tell me that it helps them, but they have to, apply it multiple times a day. That's not necessarily a bad thing, but they've got to reapply it. It's expensive because it's not covered by your typical, pharmacy benefit, basically, if you're getting it at a compounding pharmacy. Most people are familiar with topical lidocaine, which is, it's an anesthetic. So it's just deadening things at the surface. Another thing that I think actually makes sense to me is using capsaicin cream. So capsaicin is the thing that makes chili peppers hot. And so what you're doing when you apply that topically is firing those nerves up, right? If you can bear with it, because then what will happen is they'll just get fatigued and they'll start ignoring the signaling, including the pain. So that's kind of the theory behind it. It's the same theory behind using a TENS unit or some other kind of neurostimulation. Now I think of it, because I have a cardiac background, I think of it as, overdrive pacing, basically. Okay, so complications. This is a big one. If you can't feel stuff or you don't feel it properly, you could burn yourself. You can get rashes, bruises, cuts. And this kind of goes back to the people with their funny foot ulcers and things like that. You have to, if you have neuropathy, inspect the area that's affected. If it's your feet, look at your feet every day. Do not go around barefoot. They actually make socks for people with diabetes that don't have really tight elastic, and they're cotton and they're breathable. Make sure you have well-fitting shoes, roomy toe box, this kind of thing, because blisters can be deadly. If you can't feel it and you've got a blister and you develop an infection, if you look at your hands and your feet, there isn't a whole lot of distance between the outer surface and the inner surface. And God help you, once you get an infection that goes into bone, those are difficult to treat. And this is where people can end up starting to have amputations and things. So prevention is definitely worthwhile. And it's manageable. It literally is do a visual inspection when you're cleaning your feet, etc. And treat them well. Make sure you keep them hydrated. Watch out for, things like skin cracks and stuff like that, especially in our environment where it's so dry. Okay, falls. Okay, so again, I can't stress enough that the real risk of neuropathy and falling is if you can't feel or you have abnormal sensation, you are not getting messages from your feet that go up to your brain that tell you where you are in space. And so in humans, our vestibular system, which is again our balance, visual, middle ear, and then the feet, spinothalamic tracts. So what if you're somebody who has bad neuropathy or bad radiculopathy or both, because there are a lot of people that have both, and you're visual and you have some kind of visual impairment, maybe you have macular degeneration, you are somebody who is set up to have a fall. And again, not to be, I don't mean to be pessimistic about it, it's realistic. If you know what you're dealing with, you take appropriate steps. You do safety features within your house, watch out for things that you can trip on, pad your sharp corners if you have steps and things, figure out how you're going to negotiate that safely, right? And, do not be afraid to use a cane or a walker, because sort of the loss of independence or the perceived, kind of indignity of all sure beats a broken anything, or I've seen some people with some bad bad cuts and things too from these falls. And then if you're somebody who has a middle ear issue, like if you have some hearing loss, maybe you have tinnitus, if you've ever had vertigo, and you put neuropathy with that, again, so you can usually compensate if you only have one thing not working so well. Once you start getting into two or more things, it just makes you at much higher risk for falling. Okay, so treatment. I always put quit smoking in there because that's one of the best things you can do for yourself, ever. Sometimes, like we said, you can get some regeneration in those peripheral nerves. I expect to see that more in these kind of autoimmune inflammatory things. If we treat it, we get it under control, then usually they'll have improvement. And think about like trigeminal neuralgia or Bell's palsy. Those are peripheral nerves. So in a sense, those are neuropathies too. The one can be chronic or recurrent. That's the trigeminal neuralgia, but there's treatment for it. And then Bell's is usually a one-off. You don't tend to have a recurrent Bell's. Unfortunately, sometimes people do have residual weakness. But let's see, physical and occupational therapy. I'm a big fan. Can't go wrong with that. And even and there's so many different types of therapies and subsets of therapies depending on what your issue is. So, and that is true for neuropathy as well. So we talked about using multimodal pain management. Some people get injections. You can get injections along where that nerve root is. There's usually anesthesiologists that do that. You can do oral medications, and usually a combination of oral medications. You can do topical things. You can do, just be careful about things like saunas, whirlpools, pools, and things. Extremes of temperature are not good for skin that, overlies neuropathy, because you're not going to be able to tell if it gets too hot or too cold. And if you stay in it too long, you can definitely cause some damage. So be careful about that. Cannabinoids, I don't know a lot about this because, again, we don't do it in the hospital, but there are people who find that some of these cannabinoid treatments that are out there now, gummies, etc., are helpful for them. And they prefer that to being on the opiates. And when it comes to nerve pain, I will tell you, opiates are not particularly effective. If people have pain for other reasons, they have bad arthritis or something, they may need it for that reason. It's never going to be the most helpful thing for nerve pain. They just, again, work on the wrong receptors, basically. Nerve ablation. They can go in and use a balloon to crush the nerve root. They can go in and deliver current to just kill that nerve. If it's a peripheral nerve, though, it could, in theory, regrow. And I've seen that happen before with some of the trigeminal cases. Other treatments, a scrambler, that is actually a commercial name for a device that works kind of like the capsaicin I was talking about, but it's electrical stimulation, but it just delivers this thing and tries to block the pain signaling by giving its own signals. So it wants to try and suppress the pain signaling, replace it with this, which, while it may not be pleasant, at least is blocking the pain signaling. Spinal cord stimulators, so those are implanted things, but same kind of thing. You can set it, you can set the duration and the rate at which it delivers the shock. Well, I shouldn't use that term shock, that it delivers the electrical impulse. And by that, you're trying to overcome, if not completely block out, the pain signaling that's already going on. You are trying to suppress that and knock it out so that your brain doesn't perceive pain anymore from that location. It's usually done it's not like they put one in for your whole spine. It's the electrodes are going to go to a very specific spot. And they do use it in other areas besides, I'm more familiar with people having it with back and spine, related issues, but they use them on bladders, right? So they use them for a bunch of different things. There's actually a type of nerve stimulator that's used specifically for epilepsy called a vagus nerve stimulator. So immunotherapy. So I just put this one in there, efgartigimod, I can never say that right, Vyvgart. So efgartigimod. It's actually related to a medication we've been using in multiple sclerosis for a long time. I just put that in there as an example of what you can do for like these people that have now, it used to be put you on steroids and then put you on some kind of long-term suppressant agent because you don't want to have people on steroids forever. But we used to use things like Cellcept, which are chemo agents and things like that. But now we can use this in people who have CIDP, for example, or who have myasthenia gravis, which is actually a problem that occurs where the nerve and the muscle meet. That's a autoimmune neuromuscular junction disorder. That now there's kind of hope for them that they can take this immune modulating drug and do better for longer, and they seem to tolerate it pretty well. And you don't have to take it every day. It is an infusion. It's sort of stacked dosing, initially when you start on it, and then you either don't take it again for like 6 months to a year, or maybe not ever, depending on your response to it. So still got to take Mestinon, which gives you the acetylcholine, but physical therapy, surgery. Now, surgery, I don't think we need to say too much more there. This is an idea of what's out there in this. So if you ever want to know how common a problem is, go to the drugstore and see how much aisle space is devoted to the problem. Truly, that will give you an idea how common it is. And so when it comes to peripheral neuropathy, there's a boatload of stuff out there. Some of the topical things I think are helpful for people. Other ones I think might be a little bit of wishful thinking. And it's not that I have anything against supplementation, but unless you have a deficiency in something and you're replacing that, I'm not sure that taking extra of anything is going to do you much good. Because when you talk about things like vitamins and minerals, those are micronutrients. So if you don't need it, if you're not deficient, you're just going to pee it out. You're going to have very expensive urine. Or conversely, if it's, fat soluble, you could run into trouble because sometimes you can store too much of that stuff and over time become toxic from it, in and of itself. So that's why when you come in, people do want to know if you are taking supplements, and if so, which ones are they? Because sometimes there are implications with that. And there are some, these are just of all the different initials thingies that I put in there so you can translate, because I was too lazy to type them out. But, I really do think that there is a lot of good research going on. Unfortunately, you know how it is with research. We find kind of exciting things that look promising, but it takes a long time to translate that out to the public. But I do think topicals probably is an area where we could do better. And I do like this neuromodulation, whether it's nerve stimulators or TENS units. And TENS units kind of do the same things, but it's transcutaneous. That's what the T stands for. So you don't have to have any implanted electrodes or anything. And so, if you want to go and have an MRI or something, you can still have one. Now, the newer devices are usually MRI conditional. So in other words, when they put them in, as long as you've got a rep that can come and turn it off while you're in the magnet so it doesn't burn you, then, nowadays you can, not always, but often you have the option of getting an MRI. Okay, I think probably, I'm not watching, I don't have a clock, so my way, and I just put in some, places you can go if you want to find out more about these specific issues. And there are many, many things out there. I would just encourage you, as with everything else, just try to go to reputable sites and kind of get an idea of, what the goal of the people presenting you with the information is. Just be careful. If it costs you money, caveat emptor. Because I'm always a little skeptical of something that tells you it is the brand new revolutionary treatment for a common problem that I don't know about that's going to cost you money. Be careful. Okay.
Thank you, Fran. I do have a question for you that came in, and that was regarding the medications that can cause some neuropathy. Do you need to be on those medications for a long time for that to start, or is that something that could possibly start within a short period of time?
Most of the ones we're talking about that are notorious for it, kind of depends on what your definition of long-term is. If it's a chemo agent, you're not necessarily on those for years, but you might be on for weeks to months. And it's not necessarily like the first round, but it might show up in the second round, or if you have to have a third or a fourth round. So part of it is duration, and then part of it is, kind of intensity. What are you getting and for how long? And some are more notorious than others.
So if you're on any of those medications, let's say some of those chemo ones, because that seems like the easiest to sort of identify. If you were taking those, you are now experiencing neuropathy. When you stop them down the road, does that sort of help to resolve the issue, or not necessarily?
Not only not necessarily, but I would probably counsel people probably not.
Okay.
If it does, great. If you perceive that and it sort of depends on whether you have pain or numbness or both, if you perceive that it's getting better, fabulous. I would never guarantee anybody that stopping a medication is going to reverse that neuropathy.
Okay, so you could still continue on, right, with those with the long-term effects from that medication. I know you said physical therapy can help with those symptoms, so that was another question that came in. Lifestyle changes was another one to help maybe prevent falls if you're experiencing. You sort of covered that too. I know smoking was a big one that you mentioned.
Yeah.
But also utilizing your assistive devices, right?
Yeah, I'm a huge fan of that because again, and I have a 2-story house on purpose because I'm like, use it or lose it. But every time I forget something, I have to go up those darn stairs. It annoys me. But I figure that is going to keep me going into my graceful old age because, it's you balance, coordination. Everything in life is use it or lose it. Just like, your cognition and thinking and doing stuff, stay engaged, stimulate yourself, and that includes physically. And it doesn't mean you got to go out there and do marathons. It means do some kind of daily, preferably daily, regular exercise. Walking is fine. And work on things like your balance. And this is where I think physical therapy is helpful because they help you focus in on that. But you can literally every day stand on one foot for a minute, and that will do you a great thing. And switch and stand on the other foot for a minute. Because most falls happen when you cross the midline and you can't recover. So two of the things we're looking at is how do we help prevent falls? But to some extent, they're inevitable. Everybody's going to have a fall for some reason or another. So minimize the damage. If you have good core strength, then you're probably going to bounce a little better than somebody who doesn't. None of us bounce the way we used to, but that is kind of the key thing is maintain that core strength is whatever degree of flexibility you can manage. I mean, again, I'm a huge fan of things like Tai Chi or yoga because they can modify them to suit anybody's level of ability and their level of, if they have arthritis or anything like that, they can always be modified. Pool therapy, walking around one of those things and having to walk against the current, that's good for you, because again, builds up that core strength and strength in general. So there's no bad thing, I think, but there are a lot of good things that will help you going forward to minimize that fall risk.
That's great. Thank you. Fran, I'm going to thank you so much for being here. You are a wealth of information. And I know you covered so much today, and that was so fabulous to see. I'm going to wrap up with our online audience. I will turn it over to you for any questions in person. So thank you for being here.
Okay, thank you.
Thanks again for being here today. We will be back next week on Tuesday, October 1st for Real Talk about Prostate Health. That is going to be with Dr. I. Lewin with Arizona Urology Specialist. His talk is Tuesday, October 1st at 3 p.m. If you are interested in attending that class, we still have spaces available in person, and you can also watch online. Contact us at 520-324-1960. We'll see you again next week. Thank you.